While we meet today on a virtual platform, I'd like to begin by acknowledging the Indigenous peoples and traditional territories on which all of us today live, work, and play. Those of us in Victoria work and live on the lands of the traditional unceded lands of the Lekwungen-speaking people, the Songhees and Esquimalt nations. Please take a moment of reflection to acknowledge the Indigenous peoples and the ancestral lands where you are watching us from today. Before we begin, I have a few general comments. I hope that you're able to sign on to the webinar today without incident. In the feedback from the last two sessions, we noticed that a couple of people had audio problems. It seems that I was able to mute the microphone all by myself, but I think that we've sorted that out for today. If you do have technical issues, please use the email that is in the chat box and they'll give you a hand. We have a dedicated team working behind the scenes today, and you'll meet some of them as we go along. All sessions are being recorded and will be uploaded to the Heads Together Think Tank website. The recordings from the last two webinar sessions are undergoing some post-production tune-ups, and they'll be on the website as soon as possible. Once they are there, you can watch the recordings at any time. We also encourage you to send the link to the website and to the recordings to people who may not be able to attend our live sessions. This morning we'll be in session until 10:15, at which time we'll take a 15-minute break and then reconvene at 10:30. One last thing before we dive into today's session. We'd like to do a check-in poll. And if you've been with us before, you know that we use polls a few times during our sessions. All polls are anonymous, and your name will not be attached to your answer. We will publish the results of the polls on the screen so that you can see the results of everyone who's answered. Nikki, would you please launch the first poll? You should see the poll on your screen, and the question is, if you had to choose only one color to wear for your entire life, which color would you choose? And I can see that the answers are now coming in. That's wonderful. Only one color or the shades of that color, which would you choose? If there are a number of people watching one computer today, please choose one person to answer the poll today. Okay. Answers still coming in, Nikki. You can close it when you see. All right, and let's see the results. Oh, wow, looks like blue. Blue is the winner. Most people would be wearing blue, but there's good representation of some of the other colors. So thank you very much, everyone, for answering. It's now my pleasure to introduce to you someone who may need no introduction for many of you, Janelle Brees Biagione. Janelle is the project manager for the Heads Together Think Tank project, but she's been more than the project manager. She is the inspiration for all of us working on the project. She's the motivator and the coordinator for all of the work that we do together. Janelle has always enjoyed writing. She's published 7 books, including Head Injuries, The Silent Epidemic, A Change of Mind, One Family's Journey Through Brain Injury, and Life Losses, Healing for a Broken Heart. She's been published in 3 Chicken Soup for the Soul books, numerous magazines and journals, and appears in A Change of Mind, a documentary on the societal impact of brain injury. Fun fact, although Janelle loves writing books, her secret desire is to write a movie script. In 1997, Janelle entered a movie script contest, and out of hundreds of entries, she secured herself one of 60 spots to be mentored by actor-director Ron Howard for 1 week in Maui. How cool is that? Janelle, would you please join us and launch today's session?
Thank you, Shauna. Good morning. It is a pleasure to be here for our 3rd Heads Together Think Tank, our virtual event on research and prevention. This project is an initiative of the CGB Center for Traumatic Life Losses, and we're looking at the intersections of mental health, addiction, and brain injury. Our goal is to determine what programs and services are working, where the gaps are, and what can we do to improve the lives of brain injury survivors and their families. We thank our funders, the Province of British Columbia and the Vancouver Foundation. And as you've seen our website, you can go there for more information. After every event, we do conclude with a survey specific to the day, and I'm pleased to announce that last week's winner of the $25 gift card was Becky Darnbrow. I hope I pronounced that correctly. I'll be in touch with you later today. Thank you for participating, and we look forward to offering a new gift card for today if you participate in our survey at the conclusion. Last week's session was on rehabilitation and community supports. These presentations were rich with information and highlighted what is available to survivors of brain injury and their families through the health authorities and brain injury societies. We also learned about the Navigator model and supporting individuals through valued attachment. Because our presentations came from service providers, it was important to circle back to our chat and the survey to get a sense of what the lived experience is for folks with a brain injury, mental health, and addiction. I was happy to see comments that did indicate a change in perspective. For example, this comment supports the work of Dr. Dawn Castaldi. I really took home the message that although I wish to plow ahead with the plan that makes sense to me, I need to pay attention to what the client wants or needs, and that might mean something completely different from what I had envisioned for them. Other responses and comments pointed to the gaps in services. It is not surprising, perhaps it is a little confusing, as the presentations indicated that either people are served or are referred to other services. So Andrew, can I ask you to put up the slide with the graph? Specifically, most respondents either strongly disagreed or disagreed when asked if they can easily access mental health and/or addiction services. However, the majority agreed they could access brain injury services. So although they can access brain injury services, the need for mental health and/or addiction services is not being met. This comment stood out. While there are services available, there are wait lists, restrictions on accessing services, challenges of referral process, and eligibility criteria. The Brain Injury Societies noted they provide counseling, but it is based on funding through grants or contracts. This is not a sustainable service when counseling is funded this way. Nor can we expect a survivor who lives off less than $1,200 a month or a family whose income has been reduced to one person to have the financial means to pay for such a service. If anything, counseling should be available through our basic medical. As a counselor, I can tell you the parameters for counseling survivors of brain injury are restrictive. Counseling is often allowed only for 8 to 10 sessions. These are for the survivor only, and the expectation is the work would be around the outcome of living with a brain injury. However, there are layers and layers to loss after brain injury. Often, unreconciled losses from the past surface. Ethically, I cannot ignore this catch-up work because if the client is not provided with the opportunity to deal with it, the past completely gets in the way of the work they need to do now. It's rare to move a client with a brain injury from point A to point B in 8 sessions because they often require more intense and ongoing counseling, especially when mental health services such as anxiety and depression or substance use is involved. Short-term solution-focused therapy is not the preferred modality. Clients go in and out of crisis, so the path is not a linear one, and we must be prepared to walk the journey in a zigzag style. When funding for counseling ends for a client, it's possible to find limited pro bono sessions for them, but depending on pro bono work is not a sustainable service model either. Families also benefit from counseling specific to them, spouse, children, parents, as well as family sessions down the road. This is rarely available. Having said that, one of the things we do is to determine who are the natural unpaid supports in a person's life. They are expected to be involved and take on the responsibility of care and navigation. But how do we expect families to take this on, to learn the new norm for their loved one and themselves, to reconcile their own losses, to become an advocate, a navigator of a siloed system, and to keep their own mental health intact if we don't help them too? If we are to promote a holistic approach, then surely we would be including a suite of services for the entire family. In fact, it's known that 2 to 5 years with a full suite of services, including counseling, is required to come to the other side. I have also advocated the past 3 or 4 years for what I call touch-based supports. This means that a survivor and a family member can access a point person to help diffuse a situation, to navigate a new challenge, to connect with other resources as their loved one's needs change, and to be able to do so as needed, even when the service has concluded. I know that the brain injury societies and multi-service agencies such as the Courage Center for the Family do this, but these are not funded supports. These supports are given because of compassion and understanding, not because these organizations have extra money. Again, not an ideal way to ensure supports remain in place. We heard that brain injury services in the health authorities are goal-focused and restricted to those between the age of 19 and 65, and that a person receiving third-party funding does not qualify. There is no doubt that brain injury programs in the health authorities are also underfunded, hence the restrictions to access and tough criteria. Aging brain injury survivors may need more care, and while services for seniors will be available to them, those services are not necessarily delivered in a way that integrates best practices for brain injury. And yes, again, the brain injury societies and agencies like the Courage do this work, but it is not funded. Third-party funding refers to ICBC, WorkSafe, and other insurances. And while I get it that because a person with a third-party funding cannot double dip into generic services, I will unequivocally say it does not mean the person and family have access to the services they need. In fact, the focus for these folks is placed on proving relentlessly their need for service. In listening to the presentations and reviewing the surveys in chat, it's clear that education and cross-training for frontline workers would be beneficial. One slide indicated there is possibly a lack of clarity on what is, in fact, a mental health issue. Anxiety and depression, which our clients experience, are mental health issues and often lead to substance use issues. So it is relevant for workers to be trained, and all organizations, multi-service and brain injury societies alike, to have education in this area, or to be able to hire workers who are specialized in mental health and substance use. At the very least, these organizations need the ability to refer a client and know with certainty that the client will receive those services. Without this, we will see people fall through the cracks and the unintended consequences when an individual does not receive the necessary interventions and treatments. They'll result in criminality, homelessness, and substance use. A survivor of brain injury faces a 200% increased risk of struggling with addictions. I encourage everyone to watch our video, Surviving the Perfect Storm, Mental Health, Addictions, and Brain Injury on our CGB website. There you will hear Dr. Wayne Gordon give his explanation on suicidality being the end point of depression, and that one of the greatest predictors of suicide is a traumatic brain injury. Please watch the video today, and Steph will put the link in the chat box at the end of our day. Today, our conversation is on research and prevention. The purpose is to share the results of an environmental scan done Canada-wide, looking at best practices in the care of acquired brain injury and concurrent mental health conditions and/or substance use disorders. We'll be looking at the ongoing research around intimate partner violence and brain injury, and we'll share upcoming research on self-identity and brain injury. For me, good research often leads me to more questions, but I know that research has also led to significant prevention strategies. Seatbelt and bicycle helmet use are two that instantly come to mind. As you listen to the presentations, think about what can be learned from these research projects to develop prevention strategies that may lead to a reduction in the number of brain injuries and may prevent individuals from experiencing significant mental health and addiction challenges after brain injury. Research would make a difference to you and your community today. Thank you.
Thank you very much, Janelle. You've said from the beginning that you want these sessions to be conversations between people who participate in the live sessions, people who go to the website, and those who are presenting today. You've given us really good evidence of the importance of having people fill out that survey after the session, and we'll have a link for that at the end of the day. During our session today, there will be two ways for you to communicate with us, in the chat box and the Q&A box. If you're using a laptop or a desktop computer, have a look at the bottom of your screen and you'll see a number of icons. If you click on chat, it will open the chat box. If you click on Q&A, it will open the Q&A box. If you're using a tablet or a phone, then the icons might be in a different location. We'll use the chat box to hear your ideas for improving services for people with brain injury, mental health, and addictions. The chat space is for positive and constructive comments that will help us build our final report. This is not the space for airing grievances. At the bottom of the chat box, you'll see a drop-down menu showing two things: all panelists and attendees. If you've been on Zoom before, you know that chat can be very distracting if there are a lot of comments. So while speakers are doing their presentations, we'll set the chat box on all panelists only. You can still make comments, but they will go just to the panelists. The speakers won't be answering during their presentation, but we have team members here monitoring the chat box, and they'll answer your comments as necessary. When we do ask for comments from you, make sure the setting is on all panelists and attendees so that everyone can see your comments. You can certainly choose to send them only to panelists. If you haven't put anything in the chat yet today, give it a try by typing in your favorite Halloween candy. We just had Halloween a couple of days ago, and I'm wondering what your favorite Halloween candy is. And I'll just see if we've got any answers coming in. What's one favorite that's coming up, Steph? Rockets. Rockets. That's wonderful. Okay, thank you very much to everyone who's answered that in the chat. We'll have time for questions twice today. Please use the Q&A box only for submitting your questions. Dale is standing by to monitor the questions and ask them of the speakers. Now for our program. The purpose of today's session is to share new and emerging research on the intersections of brain injury, mental health, and addictions, on identity and brain injury, and intimate partner violence and brain injury. It's my pleasure now to welcome Kix Cheatone and Carly Wallington. Kix's presentation is called Ripple Effect, the 2018 Symposium to CADTH Research, and offers some background information to the study that Carly will report on called Care for Acquired Brain Injury and Concurrent Mental Health Conditions and/or Substance Use Disorders, an Environmental Scan. Kix and Carly have agreed to have a short Q&A after their presentations. This might be just 10 minutes, but they should be able to answer a couple of your questions. So please use the Q&A box to submit your questions. Some of you met Kix Cheatone last week. Kix is the Executive Director of Nanaimo Brain Injury Society and sits on the board of the BC Brain Injury Association. With a background in public health and over 20 years working with nonprofit organizations in Canada and overseas, Kix brings a passion for innovation, collaboration, and inclusive leadership. In fact, when not in the office, you'll likely find Kix in the garden, on her bike, or paddling the waters of the Sailor's Sea. Carly Wallington is based in Victoria and is the British Columbia Liaison Officer for the Canadian Agency for Drugs and Technologies in Health, also known as CADTH. And that's a bit of a mouthful, so you'll hear us say CADTH as the short name. Carly's role is to support connection between CADTH and their customers within British Columbia and to promote the use of evidence in healthcare decision-making. Prior to CADTH, Carly worked at a health-related organization with a focus on research, evaluation, and knowledge exchange. Fun fact, Carly enjoys gardening. She says she's not a great gardener, but she's slowly learning. She grew so much zucchini this summer, she stopped almost everyone who walked by her yard and offered them some zucchini to go. There's lots of us, Carly, who could identify with that. Now, please join me in welcoming Kix and Carly.
Good morning, everyone. Okay, I'm wondering if, there we go, here I am. Good morning. Good morning from the beautiful territory of the Nanaimo First Nations. I'm going to just pop up my slide here. Thank you for that introduction. And so I'm just going to give you a quick background of how we got here. So in 2018, Nanaimo Brain Injury Society hosted a collaborative community event on acquired brain injury, mental health, and substance use was included in that, but it was called Out of the Box, Acquired Brain Injury and Mental Health. And it really was a collaborative event that brought together Vancouver Island University, Island Health Research and Capacity Building Department, March of Dimes, the BC Support Unit for Patient-Oriented Research, and People First Media to bring together a multitude of stakeholders to talk about the issues that go along with acquired brain injury and mental health. We had people with lived experience involved, from the design to presenting. And this produced a summary of recommendations around integrated care. From that 2018 symposium, I presented the summary of recommendations to the Island Health Board of Directors and also to the Island Health Mental Health and Substance Use Quality Council. And a request came back from the Quality Council around what is best practice around acquired brain injury, mental health, and substance use. And this was a very good question, and we didn't have the answers. So through our partnership with research and capacity building at Island Health, we were able to then leverage and access other experts in the field. And so we connected with the Michael Smith Foundation for Health Research and also the Ministry of Health to bring together various stakeholders and people who are working in the field to say, what do we know about this? And there was talk at that point around a provincial event. We need to have a provincial conversation. So I'm so thrilled that we are now here at this provincial conversation. But back to this idea, this question, this very good question around best practice. What do we know around about integrated care? So through Wendy Young's work at Island Health Research and Capacity Building, we were then able to connect with CADTH and to participate in research to identify best practice for integrated care around brain injury, mental health, and substance use. And I'll hand it over to Carly to talk about that exciting research that now we're so thrilled to be able to have those results. So I'll stop sharing my screen and I'll pass it over to you, Carly.
Okay, thanks, Kix. I am just going to share my screen. Just trying to find the right one. So I was having a little bit of technical difficulties before we started. Could someone just confirm to me that they just see the slides and not my speaker notes as well? Kix, do you just see the slide? Maybe give me a thumbs up if it's just the slide, not the speaker notes.
Yes.
Oh, sorry, you're on. You're good. Okay, excellent. Okay, my speaker notes are on my monitor and my videos here. So if I have a little bit of eye wandering, that's why. But thank you so much for inviting me here today. I'm happy to be here to present on the findings of an environmental scan CADTH conducted, again, looking at the available care in Canada for individuals with ABI and concurrent mental health conditions and/or substance use disorders. And I also want to acknowledge that I'm located on the traditional territory of the Lekwungen peoples and the Songhees, Esquimalt, and Wasanich peoples whose historical relationships with the land continue to this day. So I'm just trying to get to my next slide. Okay. So here's just my disclosure slide. For those who aren't aware, CADTH receives contributions from the Canadian federal, provincial, and territorial ministries of health, with the exception of Quebec. CADTH also receives application fees from the pharmaceutical industry for several of our programs highlighted on the slide here today. All right, so I won't read off of every slide word for word, but I did want to provide a high-level definition of who CADTH is for those who might not be aware. So CADTH is an independent, not-for-profit organization responsible for providing Canada's healthcare decision makers with objective evidence about the optimal use of drugs and medical devices. And so really what we do is identify and synthesize or summarize the available evidence on a given topic, whether it be a pharmaceutical drug, a clinical intervention, a diagnostic. And then we give that evidence to healthcare decision makers so that they can make informed decisions. Certainly recognizing that there's many factors that influence decisions, but hopefully evidence is one piece. And just to highlight my role, why I'm speaking today, I'm CADTH's local representative for BC. And so our main offices are out in Ontario, in Toronto and Ottawa, but we have local representatives across the country. And really what we're here to do is be that first point of contact with local customers to understand the unique challenges and needs that the jurisdictions are facing to facilitate requests for evidence, etc. So if anyone's ever interested in learning more about CADTH or whether we might be able to support you in your evidence needs, please feel free to connect with me, and my contact information will be at the end of the presentation. And so here's just a little cartoon, and it says, the latest research shows that we really should do something with all this research. And so really here, just making the point again that, what we do at CADTH is to help you do something with all the existing research. So the agenda today, a little bit of background and context. Thank you, Kix, for that introduction. I'll go over some overall objectives, CADTH's approach to finding the evidence, highlight the findings of the environmental scan, highlight some limitations of the scan, and then provide some overall conclusions. So in the context of this environmental scan, ABI is defined as it says on the slide, damage to the brain that occurs after birth and is not related to congenital disorders, developmental disabilities, or a degenerative disease. Now, ABI includes both traumatic brain injury and non-traumatic brain injury. So I've just listed a few common examples for both traumatic brain injury, car accidents, falls, or assaults, for example. And then for non-traumatic brain injury, seizures, tumors, or aneurysms, for example. So a few statistics about ABI in Canada. Brain Injury Canada reports that there are an estimated 160,000 new cases of ABI annually, with an estimated national prevalence of 1.5 million cases overall. With respect to TBI, it's reported that BC has an annual incidence of 22,000 new cases added to the overall 180,000 prevalence cases. It's also reported that ABI is a leading cause of death and disability for Canadians under 40. And so from these few statistics alone, we can certainly see that it's an important issue or topic to address within Canada. Now, as many of you know, people with ABI can be affected by mental health conditions and/or substance use disorders, which could exist before or develop after the injury. So for example, one literature review in 2011 found that 50 to 60% of those with traumatic brain injury also have concurrent problems related to substance use. In a systematic review conducted in the United States, depression was found to be common among those with traumatic brain injury, with an estimated prevalence of 33% observed more than 12 months post-injury. And so individuals living with ABI and associated health problems typically require a diverse range of healthcare services, as many of you know, to treat and manage their conditions and to address their needs. And depending upon the severity and degree of persistence of ABI-related symptoms, the care and assistance needed may extend over a period of several years or be lifelong. And so why did CADTH engage in this work? Well, obviously, ABI is an important topic or issue to address in Canada. Kix spoke to some of the background context or what was going on in the background leading up to the implementation of this scan. To add to this, The availability and organizations of resources and programs to address the needs of people with ABI really varies among the jurisdictions in Canada as well as the healthcare settings. So to help inform decision making, CADTH did conduct an environmental scan, really to summarize information about the available systems, as it says on the slide, services, and integrated care centers that are in place within Canada. Essentially, we were looking to provide a snapshot of the current Canadian context when it comes to the care of those with ABI and concurrent mental health and/or substance use disorders. So now I just wanted to outline the key objectives of the scan. And so again, for the care of individuals with ABI and concurrent mental health conditions and/or substance use disorders, we wanted to identify firstly, those systems and services that are in place within Canada. And so this could be any available service or program designed to meet the care of individuals with ABI and concurrent mental health conditions and/or substance use disorders. The second thing we wanted to do is identify and describe any, as it says on the slide, existing integrated patient-centered care centers. And so here I'm talking about programs or services that specifically or intentionally integrate ABI care with mental health and/or substance use care. Thirdly, we wanted to describe how existing programs and services for ABI are funded in Canada. And then those gaps, or describe how describe unmet needs or known areas for improvement, again, in the care of this unique population. So before I move on, I just wanted to say that this scan doesn't include an assessment of the clinical effectiveness, so how well it worked, or cost effectiveness of care programs. So conclusions or recommendations about the value of the services or their place in therapy are outside the scope of this report. I did want to say that CADTH did publish a summary of abstracts report on the clinical effectiveness, cost effectiveness, and guidelines of integrated care models for ABI. The reason I'm not going to be pulling that information into this presentation today was, as I said, the scan was really meant to be a snapshot of the Canadian context. Our search for the summary of abstracts report extended beyond Canada as well. Unfortunately, there wasn't a lot of information or literature found for that summary of abstracts report. And so several reasons why I'm not diving into that today. However, I'll just let all you know that all of CADTH's reports and tools are publicly accessible and free of charge on our website, www.cadth.ca. So I think at the end of this presentation, the link to this report that I'm presenting on today will be popped into the chat box. Okay. So now on to CADTH's approach to finding the evidence. How did we do it? And so we had two main methods, the first being a focused literature search. And so in this, we had one of our information specialists search key resources for information, such as PubMed, PsycInfo, the Cochrane Library, etc., as well as identifying relevant information through a focused internet search. A little bit about the inclusion criteria. So that is how we screen the literature for eligible information. So the population of interest, as it says, is patients of any age with ABI and concurrent mental health conditions and/or substance use disorders. The intervention, whether it be a program or service, but anything aimed at addressing the needs of, again, this unique population. And the settings could be quite varied, from primary and secondary care, as it says, acute care, rehabilitation, long-term care, home care, as well as those within urban, rural, and remote settings. And just to note too, there were no limitations on publication type, except for conference abstracts, which were ineligible and excluded, really due to the limited available information within them. So focused literature search was our first method. The second method to finding the evidence was the implementation of an online survey of key jurisdictional informants and stakeholders. And what I wanted to point out here is we were really looking for those, as it says on the slide, involved in either the planning, decision-making, management, and or service provision related to ABI care. So how were survey respondents identified? CADTH has what we call an implementation support and knowledge mobilization team. It's quite the mouthful, so we call ourselves the ISKM team. And just as I'm the local representative for BC, CADTH has local reps in every province and territory in Canada, again, with the exception of Quebec. And so we use these local representatives, my fellow colleagues, to identify relevant stakeholders within their respective jurisdictions and invited these stakeholders to participate in the survey. CADTH also used other available networks through stakeholders and expert suggestions. And all participants were invited to forward the survey to relevant colleagues as well. And so the survey consisted of 33 questions, including those pertaining to, as it says on the slide, demographics, various characteristics of existing programs. So for example, the populations that are served within the facility, whether that be adults, adolescents, the homeless population, those who are incarcerated, for example, etc. The type of inpatient and outpatient services offered in the facility or jurisdiction, etc. Now, we were also interested in the types of patients accepted. And so by that, I mean whether someone has mild, moderate, or severe TBI or non-traumatic brain injury. Obviously, we were interested in systems, services, programs that integrate mental health and or substance use care in the ABI programming, as well integration of Indigenous practices, wait times, and unmet needs as well. And so responses were analyzed by the objectives of the survey, or the scan, sorry, and then by jurisdiction where appropriate. So quantitative and multiple choice answers were summarized through tables by jurisdiction and presented narratively. And then qualitative, those open-ended answers were categorized using thematic analysis and presented through tables and narratively. And so just to say, if you're interested in more details about a specific jurisdiction's response to a specific question, that can all be found in the tables within the appendices. And so feel free to take a look at that report after this presentation for more information if you're interested in that. Okay, so a few notes about the respondent demographics. And so the survey was distributed to 32 stakeholders representing 6 Canadian provinces. So the provinces you see on the screen here, as well as Nova Scotia and PEI, it was also sent to one federal healthcare plan. The survey, unfortunately, was not distributed to the remaining provinces, territories, and federal healthcare plans, owing to a lack of identified stakeholders in these jurisdictions, which is certainly acknowledged as a limitation of this report. The other thing to note is that this survey was implemented around the time or shortly before really a national lockdown of the country due to COVID-19. And so it's very likely that this unique situation we're in would have impacted response rates as well. So in the end, 22 respondents representing 4 jurisdictions, Alberta, BC, Ontario, and Saskatchewan, were captured in the survey results. You'll likely take note that there is only 1 respondent for BC. I wasn't in this position when the survey was being implemented, and so unfortunately I don't have a lot of details beyond in terms of who it might have been sent to within the province, but just highlighting, not only the limitation that some jurisdictions aren't represented at all, but that some jurisdictions, specifically BC, do have a low response rate. So again, a limitation of the report. And then the sectors of employment represented included, as it says, provincial government, academic or research institute, not-for-profit or foundation, and private. The geographical work settings of respondents was urban, rural, and remote. And as it says on the slide, organizations or facilities represented by the survey respondents engaged with a variety of populations and all severity levels and types of ABI. Now, with respect to the literature search, we included 7 articles that fit our inclusion criteria. So that is, they address the research questions. And all 7 articles were from authors in Canadian organizations published between 1999 and 2020. Okay, so on to the key findings. So similar to the report, I'll be presenting on the findings from the survey and literature search separately, and then summarizing some overall conclusions at the end of the presentation. And so 22 respondents from the 4 Canadian provinces provided information on systems and services for individuals with ABI and concurrent mental health conditions and/or substance use disorders. And all 4 of these jurisdictions highlighted that systems and services do exist for the care of those with ABI and, again, mental health conditions and/or substance use disorders. The characteristics of the individual programs vary, and in many cases, and probably not surprisingly, the mental health and/or substance use care is a standalone program that is offered concurrently to the ABI rehabilitation program. Nevertheless, examples of services offered include case management, community services, rehabilitation, support groups, recreational services, and reintegration programs, whether that be into the workplace, school, or community. Now, with respect to the literature review findings, the survey findings I just noted are generally in line with findings from a 2014 mixed method study of community healthcare services for ABI in Ontario. And I'll actually be bringing up this study several times throughout the course of this presentation. And in this report, the authors concluded that few organizations were equipped with in-house mental health care staff. However, the authors did identify some models and programs that could effectively be used across the province, such as it says on the slide here, the Pediatric ABI Community Outreach Program and the Substance Use and Brain Injury Bridging Project, which I will actually elaborate on a little bit more on the next slide. So with respect to the question about available integrated care centers, so those programs are services that intentionally integrate mental health and substance use care with ABI care. Again, 22 respondents from the 4 Canadian provinces provided information. Survey respondents indicated that programs integrating mental health conditions and/or substance use disorders with ABI care are currently available in all 4 jurisdictions. However, not every program identified by the respondents was an integrated program. So, for example, of the 5 programs identified in Alberta, 3 were identified as having integrated mental health and/or substance use care, while 2 were not. Of the 9 programs identified in Saskatchewan, 1 program was identified as having integrated care, 5 programs were not, and information wasn't provided for 3 other programs, while both programs in BC were acknowledged as having integrated care. Now, one example I did want to highlight of an integrated care center is the Community Head Injury Resource Services, or CHIRS, program in Toronto. And they developed the bridging project, the Substance Use and Brain Injury Bridging Project, which I had noted on the last slide. And really, this project was developed to facilitate the care of clients living with ABI and problematic substance use. And so this project introduced treatment alternatives for clients of CHIRS whose cognitive impairments really precluded them their treatment or their involvement in mainstream substance use programs. And so according to the CHIRS website, this was accomplished with close collaboration and cross-training with the Center for Addiction and Mental Health, or CAMH. I also wanted to note that 13 respondents indicated their facility was involved in the care of Indigenous populations with ABI, and 6 respondents indicated that their facilities actually incorporate Indigenous practices into their services. And when it comes to the literature review findings, actually no literature was identified for integrated care centers. And so that's something to note. Okay, so now looking at funding sources for systems and services for this unique population. Really, it was a mixed bag of publicly and privately funded programs. I won't get into all of the nitty-gritty details here, but a few points. Of the 5 programs, again, identified in Alberta, 3 were locally funded, either through local health authorities or hospitals. 2 were publicly or provincially funded, one of which also identified fundraising as a funding source. Both programs in BC were identified as being privately funded, one of which was locally funded. Of the 16 programs identified in Ontario, most indicated receiving multiple sources of funding. So again, a mixed bag. When it comes to the literature review, I will bring up that 2014 study again coming out of Ontario. And the survey results from this article found that funding came from a number of streams, and I just put a few on the slide here as examples: the Ministry of Health and Long-Term Care, Local Health Integration Network, private insurance, etc. Okay, so the last major objective, as you'll recall, is identifying those gaps or known areas for improvement when it comes to the care of, again, those with ABI and mental health conditions and/or substance use disorders. So maybe not surprisingly, all responding jurisdictions identified limited funding and resources as a barrier to care. So for example, limited staff or alternative health professionals, limited education. Respondents also highlighted the barriers of access and timeliness to treatment. So for the literature review results in the, again, 2014 study of community and health services of individuals with ABI in Ontario, the authors underscored the need to break down siloed care between agencies, systems, and funding sources. And this call for integrated care is largely echoed in other publications as well. A 2019 Canadian study on intimate social relationships in adolescent girls and women with TBI identified that women of all ages with TBI report more symptoms of poor mental health, especially depression and anxiety. And so the authors highlighted the need to provide gender-specific support for individuals or for women with TBI as they develop intimate relationships. And this is supported by 2 separate retrospective cohort studies in Ontario, which identified gender inequalities and vulnerabilities in really the clinical profile of individuals with TBI, and that this should be reflected in care programs. And then when it comes to Indigenous populations, a 2011 Canadian qualitative study noted a lack of awareness, education, and resources available in Indigenous populations. And these themes have been echoed in other publications as well. So before I go on to some overall conclusions, I did want to highlight the limitations of the report or the scan. And so I did want to begin by saying that the findings of this scan really present a broad overview of care programs for people with acquired brain injury and concurrent mental health conditions and/or substance use disorders, based on, as you know, a survey and focused literature search. It's not a fully comprehensive review of the topic. So for example, there may be ABI programs across Canada that are not well documented, either in the literature or online, and therefore they would not have been captured in this report. I also wanted to note that the quality of the included studies in the literature review is uncertain because a critical appraisal of the literature was not conducted for this project and because of the broad inclusion of publication types. Now, as you'll probably gather by now, the identified literature was largely regarding Ontario programs and services, while literature discussing other Canadian jurisdictions was not identified. And so there certainly is a limitation there. As well, there was a lack of information, as you may recall, available regarding those integrated patient-centered care centers, including those based on Indigenous practices. And with respect to the survey, the information was obtained really from quite a small sample, and it isn't representative of all provinces and territories, which again is a primary limitation of the report. Surveys were sent to stakeholders identified by CADTH and other stakeholders and experts in the field, and it's likely that not all relevant stakeholders were identified and contacted. And this likely goes both for the jurisdictions, again, that weren't represented at all, but also for the jurisdictions or provinces that were. And this potentially creates a gap in valuable information regarding ABI care programs. So with those limitations in mind, I thought I'd provide some overall conclusions and maybe even some implications for decision-making or policy-making. So to begin, there are numerous types of systems, services, and programs in Canada for individuals with ABI. However, in the presence of mental health and or substance use comorbidities, the care for these concurrent conditions is usually siloed. Both survey results and the literature findings signaled really a need for greater integration as key to improving care and patient outcomes. Now, according to the survey results, some community associations have recognized the needs for this unique population and have begun collaborations and cross-training their healthcare staff between these care sectors. In cases where there is incorporation of Indigenous health practices, it was noted that some programs partner with Indigenous health centers to deliver care. However, the extent of the integration wasn't clear. Now, another point, most programs are publicly, provincially, or locally funded. However, a small proportion rely on foundational grants and fundraising efforts as well. And another point, areas for improvement were numerous and revolved mostly around funding and resources, as well as timeliness to treatment and access to treatment. Generally, these underscored again that need to break down siloed care between agencies, systems, ministries, and funding sources. Another area for improvement, according to the literature review, was brain injury awareness and prevention programs, both among the general public as well as healthcare practitioners. And so, for the latter, healthcare practitioners, enhanced screening programs may help disentangle ABI from many other factors, particularly in cases where the patients first present with a mental health condition and or substance use disorder. And lastly, maybe I'll just say, the limitations of this report, particularly the lack of representation from all Canadian provinces and territories, should be considered when interpreting the results. And, further work that evaluates the implementation of integrated care for this unique population may provide additional insight into the complexities of the interventions. And then alternative approaches to information gathering and opportunities, for example, for broader engagement and enhanced communication and collaboration among relevant stakeholders may provide guidance for future research and understanding in this area. And so that's why I think this gathering today is a really great example of creating the space to engage and collaborate with relevant stakeholders and to broaden our understanding of this very important topic. And so with that, here are the references for today. You can find all the references and the full report again on our website. And my last slide. So if you're interested in getting a hold of me, there is my contact information. And I think we will go to a poll now, and then I'm going to hand it back over to Kix. Again, there wasn't great representation from BC, so Kix kindly enough agreed to provide a little bit more context when it comes to the BC perspective. But I think, okay, so it's not a very elaborate question, but just interested, do the results of this scan ring true for you? Absolutely, kind of, or not at all? Okay, so 53% absolutely, and so about half and half, absolutely and kind of. Thank you. Okay, Kix, I think I'll pass it over to you now.
Great. Thank you so much, Carly. I really appreciate the depth of knowledge and information that was presented in that research. And I think, you know, any research we do has its limitations. So this is a great starting place. It's a great opportunity to see what is happening nationally. And as you said, you know, this has been in the works for a while, but when it was launched, it was just at the COVID lockdown. So I have no doubt that people had other things on their minds, even though, you know, that the survey, they may have thought that, you know, this is really important. There was a lot going on at that point. So I think that recommendation that you put forth, Carly, around that broader engagement to see, you know, what exactly is happening in BC to look at these concurrent issues. And I can say that I was looking back to the recommendations from our community symposium, which included people with lived experience, researchers, academics, caregivers, students, health providers, people from service organizations. The recommendations are very similar to what we saw in the research from CADTH. We heard the recommendations from the stakeholders in 2018 about investing in integrated programs that enable those with combined ABI, mental health, and substance use to access appropriate treatments and supports. And also to consider ways to reduce caregiver burden as well for families. So we talked about that siloed care in our context in Nanaimo, and we heard about it again nationally. That was a recommendation to look at how can we break down these silos. We heard last week around the rehab and community supports that are happening around BC, and we know that there is very good work happening to really support the whole person on their journey of recovery through brain injury, as well as the family, and to really look at that integrated holistic approach. So we do need to look at what is happening in BC, and I have no doubt that we'll find similar approaches, and to also learn from what we heard is going on across Canada, and to say in BC, well, what can we try? You know, that we don't need to reinvent the wheel. Carly brought up the study, the 2014 study around that, the bridging project. I really feel like, you know, we don't have time to waste. So, you know, we can learn from each other and really see what is happening with that broader engagement, find out what is happening in BC, and also to move forward. There are communities that are ready to move forward. In Nanaimo, I can talk about, you know, that confirmation of the recommendations that came forward from community, that confirmation from the national scan. Now let's look at doing some implementation and finding out, you know, how this works in a local context. So I'm absolutely thrilled that we now have this national scan, and that this is a jumping off place for many communities around the province, because people are at different places. And so this can provide hopefully ballast and trajectory for the next step for our communities in terms of research priorities or implementation projects, trying to see what can we do to really break down those silos and provide that holistic integrated care that we know works for people. And you know, Janelle talked about that at the beginning. Like, this isn't a quick fix for people. We need that long-term investment to make sure that people are really, they feel supported in moving forward in their life in a meaningful way. So I'm really excited about this research, and I'm so grateful for the opportunity to work with CADTH and also to have the support of our local health authority, Island Health Research and Capacity Building, and the work of Wendy Young and her. I borrowed her slide of the ripple effect. So we really, I feel supported, at least in our local context, to continue to move forward. I think people are really coming to the table with a spirit of generosity and a willingness to say, yes, these are issues. We're not going to back away from them. And there are systemic barriers that we face in terms of governance, funding, resources. There are real barriers that we need to look at, structural barriers that prevent us in moving forward in implementing that integrated care that we know works. So I am going to open it up to any questions. As we see in the chat, please put your questions in the Q&A box, and we'll do our best to address questions from the audience. Well, one question I had is, Carly, in terms of how CADTH gets involved in communities, if there are other, your recommendations for research, how does this work for organizations and communities to engage with CADTH on these research opportunities?
Okay, sorry, just waiting for the host to unmute me. So yeah, Kix, that's a great question. And so one thing I didn't cover today is that our customers at CADTH are really anyone who has a stake in the public healthcare system. And so that could be folks within the Ministry of Health. It could be folks within health facilities such as long-term care hospitals, within regional health authorities. And so as I had noted, I am that local representative, and so I'm here to engage with people when they have questions about CADTH and whether we might be able to support them. And so oftentimes customers will just come to us and ask if maybe first of all we've done any work on a given topic. And so as I noted, even if you aren't a customer per se who could receive services or support from us, all of our reports, tools are free of charge, publicly accessible on our website. And so sometimes we can just provide information to you that way. But customers will also come to us and request evidence, and so we'll undertake new projects for them. And so this was one where Island Health came to us through connection with UKICS and others, and had a project in mind or a question in mind, and so we worked with them to create this project and get them the information they need. And so really I'm here to chat with people if they have questions. We're here to support you through the beginning stages of the initial request for evidence, and we'll walk with you through the entire process all the way to when the report's released or decisions have been made. We can offer implementation support like a presentation today, connecting with different stakeholders to provide those key findings to them so that they can make informed decisions. So implementation support as well. And so, yeah, I mean, the bottom line is if you're interested in support from CADTH, or whether you have questions about whether we could support you, the easiest way to go about that is just connect with me, and we can have a conversation about your evidence needs and then go from there.
Carly, this is Dale. We have one other question for you and Kix. It was noted in the research that there was gaps in access and timeliness to services. And I'm just wondering if the research either showed, or maybe Kix has some experience on how access to mainstream addiction services for those with TBI could be improved.
I think in terms of the question of how it might be improved, I'm going to let Kix take that one. I'm by no means an expert in the field or work within this field. Kix, if that's okay, I'll let you answer that one.
Yes, this is the big question, right? And we can always go back to funding and to see how funding is allocated, but also I'm going to speak to kind of the elephant in the room, but this idea that we kind of are maybe a bit territorial, or maybe a bit feel like our area of care or service should be prioritized. And I think there's a real need to look at how structures are in place that create these silos so that people can't communicate with each other easily. And so, and it does come down to funding, you know, in some ways. Whereas, you know, if we're working with someone with acquired brain injury and there is funding allocated through the Ministry of Health, through the health authorities for someone with acquired brain injury, and there's criteria that they can access those services, it sometimes doesn't work very well for that person to then kind of cross over into the mental health and substance use bucket of funding, because there's different criteria, and not that these two areas don't want to work together, but it is and again, I work within the community side of things, so I will plead ignorance and just from you get my perspective, but it does seem like there are some real structural barriers to how somebody moves between services, health services, how they are, the criteria that is required for them to get services over here with acquired brain injury and then over here with mental health and substance use. So how do we improve things? This is the major question. I think looking to other jurisdictions to say, how did you do it? And to say, yes, we can do that here. And to really, I know this is bigger picture thinking, but really to look at what are the governance structures, how are decisions made, and are they being made in the best interest of the patient, the client, the family, or are we dealing with something that is kind of a relic of how decisions were made, and they don't necessarily fit for our current context. And so there's an updating that needs to happen here so that we can really bring in that complexity, that collaboration, that understanding that it is a collective impact. These issues that we are facing in our communities, in our families, require a real collective approach. We need everybody's brains, we need everybody's perspectives at this table, because it is very, very complex, and none of us can do this on our own. No one person, no one sector, no one organization has all the answers. So from the community perspective, we really rely on our partners in the community across sectors, in the business community, in the health authorities, in the universities. We really require everyone to come to the table to address the complexity that we're dealing with, and some of these relics or systemic barriers that, you know, potentially served us previously, that it was actually important for us to have specific areas of care, but we need to really update and understand that things aren't working. And we're not dealing with gaps in services. I spoke to this before. We're dealing with massive chasms that people cannot get over. They cannot navigate on their own. So the way to improve, it's a long-winded answer, but it's really, we need to come together and really address the systemic barriers in governance, in funding, and to look at how we can really come together, not only with a generous heart, but also with the authority and the power to really make change. Okay, that's my long-winded answer. So
Thanks,
thank you.
Kix.
Kix and Carly, for your presentation today. I think you've given us a lot to think about. I've worked in healthcare for decades, and I must express to all of you who are listening that CADTH has a tremendous reputation for research in this country. And to have a resource such as this environmental scan is a wonderful piece of work that all of us can use as we work with partners, as Kix said, to look at where there are the gaps or chasms, where there's opportunity to change and shift. In conversations with funders and policymakers, research goes a long way. And so despite the limitations that you outlined, Carly, this is really a tremendous resource for everyone in the community to be able to use. And I thank you both. I thank you both. If you have further questions that come up after today's session, and I know I very often think of one on the way home, thinking, well, I should have asked that earlier. We do have the Heads Together think tank discussion groups, and there is one for research prevention for today's session. And please post your questions there. We'll monitor the discussion group and make sure that your questions are answered. Before we go to break, we have one last thing for you to do, and this is a reflection, and then we'd like to hear your answer in the chat box. And it's a pretty simple question. Janelle brought it up earlier today. We need to learn. We need to learn from the research. So what did you learn from the research presented this morning? Kix in her presentation of how it led up to the environmental scan, Carly in the results, and then Kix in implications. So please, in the chat box, what did you learn from the research presented today? Excuse me for a moment. Okay, we're going to take a break. I'm going to take a drink. About 15 minutes, you'll see the word clouds from the last two sessions rotating during our break. So see you back at 10:30. Thank you very much. Welcome back, everyone. I hope you were able to stretch and get some refreshments during the break. Get comfy in your chairs again for the second half of our program. First, we thought we had some really good comments in the chat about what you learned from the research presented. We're going to keep all of those comments, and we'll save them and read them and refer to them for our final report. A few that stood out for us, though, there was one, and I can't read all of it because sometimes they get a bit long. More applied research is required to support sustainable funding models for integrated care. More applied research. That's great, that came out. Another comment, there's a lot that we can do to support the world. Love the positivity in that one. And also you're learning what goes on behind the scenes. Very often the research as it's taken into lobbying efforts is behind the scenes. So I'm glad that you're learning some of that. So before we start our next session, we'd like to find out who's with us today. This is a poll that we run in every session. We're going to run it again today. So Nikki, if you could launch the poll, and if you could just identify which statement best describes you. Are you a brain injury survivor, family member, service provider, funder, or interested observer? This is really helpful for us as we're looking at next step for us. Who are you as you're here? So we'll see how many of you vote. We've got a fair number of service providers again. Thank you very much. And Nikki will close that down whenever the responses begin to slow. So here we go. a majority of service providers. So thank you very much for joining us today. The first half of today's program was about research on the intersections of brain injury, mental health, and addictions. In the second half, we're going to look more closely at two things: self-identity and brain injury, and intimate partner violence and brain injury. We begin our second half with a presentation by Dr. Julia Schmidt called Doing and Being After Brain Injury. Dr. Julia Schmidt is interested in improving everyday life for people after traumatic brain injury. Her research investigates neurological changes, psychosocial and cognitive consequences, and individualized rehabilitation strategies for people after brain injury. Julia's research is informed by her clinical experience in brain injury rehab as an occupational therapist. Her work is based on a patient engagement framework of research and evidence translation. Dr. Schmidt is an assistant professor in the Department of Occupational Science and Occupational Therapy at the University of British Columbia. She obtained her Bachelor of Science in Occupational Therapy at the University of Alberta and her PhD at the University of Queensland, Australia, focusing on cognitive interventions for people with traumatic brain injuries. Please join me in welcoming Dr. Julia Schmidt. Julia.
Hi, thank you, everyone. I'm so excited to be here, and thank you, Janelle, for inviting me. So as mentioned, I'm an occupational therapist. So when I'm talking to you about identity after brain injury, I'm also talking to you about what we do in our everyday lives and how we showcase who we are by what we do. So what I'm going to speak about is not necessarily mental health and substance use, but we can see how self-identity and who we are is so intertwined by what we feel about ourselves and how we respond to it. So we know that who you are influences how you feel and how you cope. So the addictions and substance use issues there. And before my current research role, as mentioned, I'm an occupational therapist. I worked for 10 years in a rehabilitation setting, and that's made a huge impact on my research and the questions that I ask. And I feel like it grounds me in what I feel is important issues in this topic. But also as a fairly newbie academic faculty member at UBC, I partnered with people with lived experience and more recently people from brain injury associations, just to make sure that what I'm asking and of the research is actually truly important and necessary for the population. I really see myself as a server for this population, and yeah, I hope to still stay grounded in the important topics. And yeah, having stakeholder voices is just quite important for me. So. Let's start this presentation here. I'll try and make this as interactive as possible. I know this is strange in this virtual world, but there's plenty of reflections and things I can do with you all today. I'm in Vancouver in my dining room table, and that's the traditional land of the Musqueam, Squamish, and Tsleil-Waututh peoples. And as I said, I'll use reflections, stories, and lots of theory and research data in this talk. But first, to bridge this talk, I'm going to show you this piece of art. So this piece of art was completed by Margie Lalonde. She had a traumatic brain injury in 2016. And this piece of art was found from my students who are doing a research project on using art in a teaching context to really facilitate student learning of somebody's experience of brain injury. We hope that students will learn beyond the skills and techniques of brain injury rehabilitation, that they'll understand the loss and the trauma and the changes in self-identity after injury. And like many survivors of brain injury, Margie Lalonde uses art to help reconstruct her own sense of self and try and make sense of the injury. She says, many survivors grieve the loss of an integrated and valued self, and it can take years after traumatic brain injury to reconstruct positive self-identity. And that's what we've heard from talks in the past, and I will tell you again that right now. And so perhaps now we can have a look at this picture and keep it in our mind as we talk about some of these aspects. Now, as a researcher and teacher, I just can't help but writing learning objectives for all the talks that I give. So today we'll talk about what happens to the self after brain injury. And of course, I'm talking from a research perspective. There's been beautiful stories 2 weeks ago about people's lived experience with brain injury, and now this is from a research perspective with theory. We'll talk about the connection between who we are and what we do. And we'll talk about some aspects of intervention that can help rebuild self-identity after brain injury. And spoiler alert, there's not a lot of research out there, but I'll bring some of it to this presentation, the stuff that we do have. And then talk about what more we can do in this area. And I hopefully have some tangible things that I'm doing. And so I hope that, you will hear that self-identity is really an important aspect after brain injury. It's something that's very affected. And I also want to recognize too that, most of you are service providers in the area of brain injury, or people with brain injury itself, or carers. And I know that this is probably not new information, but at least I hope to add a layer of knowledge, or perhaps from a different perspective. So first, I want to ask you, and if you have a pen or a piece of paper, or just to write this down, I want to ask you who you are. So reflect on that, and maybe as a prompt, what makes you you? Perhaps you might want to talk about adjectives, so things about yourself. Perhaps you want to write down some of your roles or what you do, or just descriptive words. But just take a minute. It doesn't have to be long, and it won't be shared with anybody, so you can be as honest or not as you'd like, just as long as you try and participate, because it might just help us in framing these conversations. So who are you and what makes you you? But let's put that aside for now, because it's story time. And I'm going to tell you about a story about Sam. Now, I'm going to actually use a stuffed animal for this story. This is Sam. Hello, Sam. And I'm going to use a stuffed animal as opposed to a real person or a case study or a research participant of mine. Because that way, we have all implicit biases of sex and gender and culture and race. And hopefully using a stuffed teddy bear gets a little bit away from those biases. And also maybe it'll be a little bit of fun too. So let me tell you a story. I asked Sam, this stuffed teddy bear, Sam, who are you? And I also added a prompt, tell me about yourself. Well, Sam says this. Sam says that he's a parent, a friend. Sam's creative. Sam's a runner. And Sam is, of course, a stuffy. So as a researcher using theory about identity, there's a lot of ways that we can look at this, who are you, or what we talk about when we talk about ourselves. As I said, Sam's a parent, so he's lots of cubs, a friend, maybe he goes on some walks with his friends, creative, runner, and a stuffy. Maybe he does a lot of cuddling. So we can think about theory, think about identity using theory of social identity. So social identity theory talks about how oneself is influenced by and influences their social surroundings. So perhaps as having some bear cubs, Sam's identity as a parent really takes shape. And also having friends, there's an identity link in that. Identity is also thought of in terms of self-identity, and that's actually the word that we often use when we talk about identity is one's self-identity. And in Sam's responses, maybe as a researcher, I would categorize that a feeling of being creative and that sense of being a runner as in the self-identity. Really, a lot of things that are more social can still fit in this. That's kind of our catch-all phrase oftentimes. in a lay language. We also think about identity as in the roles that people have. And really, that's most of the things that Sam just told us. Being a parent, he has a role of being a parent. A friend, that's a role. Being a stuffy, of course, that's a role that he carries. And, you know, before that, the runner, being a runner is a role that Sam has in his life, and that's how he carries himself. Identity can also be thought of in the attributes or the personality traits that people have. That's sometimes also how identity is thought of. And for Sam, it's the creative and maybe friendly, because Sam has friends. So then we know that from mine and other people's research, there's a link between the identity, who we are, and what we do. So let's have a look at it in Sam's case. I asked Sam, what do you do to express who you are? And so as a parent, Sam does a lot of homework with his kids and does drop-off, loves to do the school drop-offs. As a friend, Sam expresses that through going for walks with the friends. And Sam expresses his creative side of his self-identity through cooking and gardening. Maybe he has some blueberry bushes out in the back. And as a runner, Sam expresses that by running, by being active, maybe in the trails, in the forest. And as a stuffy, does a lot of cuddling. So that's how Sam expresses the identity of being a stuffy, is by cuddling. And we know from our research and others, again, is that the connection between the identity and the occupation or activities. I'm an occupational therapist, of course, so I say occupation, and I mean the things that people do in their everyday life. That is very connected, and that's a long time since theory that we've known, and we see it in the traumatic brain injury area too. Everywhere that identity and occupation are linked, and that's when it's a healthy and a good link, then it's strong, and it's a good. And when I made this slide, I just couldn't help myself have a little bit of fun, just to remind ourselves that when the link is strong and good, then it's wonderful. Look at that nice, happy face. So identity and occupation, when it's closely and strongly linked, it's good. When it's on top of each other, you don't want a one-eyed monster, but having it separate but linked is a good thing. So back to our story then. You know where this is going. Sam is going to have a traumatic brain injury, because we're here talking about the traumatic brain injury and the intersections of mental health and addiction. So unfortunately, Sam got hit by a car. And what that now, Sam, spent many months in hospital and rehab, and Sam can't walk. Sam can't communicate and cannot remember things. So this is a very typical situation, what happens to people after moderate to severe traumatic brain injury, and of course stroke as well. So everyday activities are a strain for Sam. And that's, problematic for living his everyday life. So have a look at what you wrote down earlier when I asked you who you are or what makes you you. Reflect on, if you were in that situation and couldn't walk or speak or remember things. And for those living with a brain injury out there, you don't have to think hard, I'm sure, to reflect on that. What if you couldn't do any of those activities that you thought were meaningful, even the simple things like going for a walk outside? How would that affect your sense of self or your self-identity? So back to our story then. What happens to Sam? Well, Sam ends up able to go home after months of rehab, because there's lots of supportive friends and family involved. And this is a very fortunate situation. And I know most people after brain injury don't have this opportunity. And in fact, we know that a lot of people after brain injury end up on the street and are homeless. And but so Sam is lucky, so to speak. He is able to go home. And then after a year of his injury, I asked Sam the same thing. I said, Sam, tell me about yourself. Who are you? Sam's, Sam, like a lot of research participants we see, so there's a bit of a pause, and maybe we do the same thing. We're kind of not sure where this question is going, but Sam might say that he's now a traumatic brain injury survivor. And I asked maybe what about being a parent, but he's not sure how, if he still, I guess he still is one, but how is that really, that doesn't, he's unsure, and is not really sure about those roles and identities that he has. And maybe Sam even says, like I've heard from a recent participant, that he's less of a person, or smaller, or less valued. And maybe Sam still says things about his attributes like being creative, but not sure how to express them. So these are real things that we're hearing. And I asked specifically then, Sam, how do you express yourself? And because Sam can't walk or communicate really, or remember things day to day, it's very difficult for him to say, do the school drop-offs for his kids. He can't go for walks for friends anymore. Maybe he doesn't even want to try to, garden his blueberries anymore. And he can't walk, so how can he even do his trail races? So it's quite difficult for Sam. And remembering how these theories, this theory of how the self and the occupation or the activities that we do are quite linked. When the occupation is missing or is gone, then there's less of an ability to express their sense of self. And when this is the case, people may lack meaning and purpose. And this is where depression and mental health issues come into play, and how people cope with that, potentially through addiction or substance use. And when people can't physically or cognitively do something that adds to their sense of self or purpose, this comes into play. So here's a quote from a colleague of mine's research. This is from a person with a traumatic brain injury when asked about the self-identity. I'm a very different person to who I was. I think myself, inside is still me, but it's the who I am, where I fit. That's what I don't know anymore. And we are hearing very similar things in our research. So how are we progressing, and what are we doing in research to address this? Well, it's interesting, like 10 years ago was one of the first, I'd say, real marks in this topic area. And it was a special issue in Neuropsych Rehab, which is a publication, a journal that looked at the self after brain injury. And we're doing another 10 years later, another one. Well, it'll be 11 years later once it gets out. And hopefully the articles and the research that we publish will take another big step forward in this area. But for me, I'm partnering people with brain injuries, and I think that's really important, as I said at the beginning. Two main studies that I'm doing right now is understanding the relationships with other factors. So we have the sense of self-identity and the occupations, but gosh, there's so many other bubbles that we can put in. And for simplicity's sake, I left it quite blank there, but and just having the two bubbles, but there's lots of other things like quality of life might sit over there in the sense of self. And the cognition and physical capacity or emotional well-being can fit in there, but we really need some tangible evidence to kind of make up that model and that theory, because then when we think about interventions, we know if we turn one dial up on, say, cognition or mental health, then perhaps the other things might have a flow-on effect if we really understand the relationships. And then the other thing that we're doing, and this is a recent partnership with some of the brain injury associations, is exploring the needs and priorities from people with brain injuries and carers on how to improve their quality of life. We talk about quality of life, and we really mean everything of self-identity and the occupations. So we're hoping that these these small things will, start to be a catalyst for future research. And I'll talk about specifically interventions and what we're doing in that area later on. So let's go back to our story and let's make a happy ending, because I'm the storyteller and we get to finish with the happy ending, even if it's not very common in real life. We can do that in pretend land, can't we? So so Sam, he actually gets a lot of support from the community organizations, and that's just wonderful because we know that that's not very common. But Sam ends up being able to have counseling and psychological support. And things that Sam does are he gets some specific loss and grief support. And that's really, and he gets, through that, he feels a sense of self-compassion and self-acceptance. He also has a lot of TBI or brain injury group support that he goes to. Perhaps it's the Navigator program that we heard about, or peer support. And that's just wonderful because then he can start to have lay the groundwork for some healing and support directly for his sense of self-identity. Then also on the activities or occupations, what Sam does is he receives some physical and occupational therapy support, maybe, to improve some of those impairments that he has. So physical impairment of walking, maybe the physio is able to now retrain him to be able to use a walker and be able to walk in the community. And the occupational therapist can help him increase his safety awareness so he can have a bit more capacity in the things that, so that he can start to do things that make up his sense of self. Also, which is very common after brain injury, and what a lot of the allied health therapists do for people with brain injury is they help modify the way the activity is done. So look at what Sam's goals are, and maybe there's a new way of doing things. So let's think about the role as a parent that Sam had, and that identity that he had, and thinking about the fact that he wanted to drop off his kids. Maybe for Sam, after the physio improved his walking and the occupational therapist improved his safety awareness, maybe then also Sam would modify the way the activity is done. So walking to school, perhaps slightly before the rush, so that there wouldn't be as many distractions or tripping hazards or issues around. Or perhaps maybe the solution is to walk during the rush so that Sam doesn't have to remember the way where the school is. He could perhaps follow a neighbor as they are walking to school. So that's, an example of modifying the way the activity is done. Another very common thing that happens after brain injury, and we all know this, is that Sam might explore new activities that he hasn't been able to do or hasn't needed to have to explore because he's been having all of those roles and identities before. But maybe there's a new activity that can still channel into his sense of self as a parent. So perhaps instead of helping with homework like he used to do before his brain injury, because he doesn't have such cognitive capacity or memory for that anymore, maybe he helps his children do homework instead of helping with, maybe he helps his children with reading instead of homework because he can just listen to that. So then Sam is able to have a nice happy ending. He is able to do all the things that he wants to do, like reading as homework and going for coffees instead of walks, has simple gardening instead of his major garden, and maybe he's a volunteer in the running races. So I want to end with that, but I also want to say that there's, as I said, there's a lot of work still that we need to do in this area. I didn't mention, and I know I have just 1 or 2 more minutes, but there was a systematic review that was done and on self-identity after brain injury, and even a book that actually my PhD supervisor published. It's called Self-Identity After Brain Injury. And there's some assessments and there's some interventions, but really these interventions haven't been tested at a high level. So there's really just case studies and some review of theory that's been out there, but not a lot of high level evidence. But there are, I hope that there is some degree of more hope in this area with, say, a colleague of mine is doing a group intervention, an 8-week group intervention about valued living after brain injury. So there's some more research that's being done in this area, and I hope that we can continue through things like understanding all the relationships and understanding what brings quality of life to people after brain injury. So thank you so much. I'm happy to take questions. I know we may not have time for questions, but if people want to contact me afterwards, I'm happy to talk. And please also watch this space, because some of our recruitment will be starting in BC next year for some of the studies I mentioned, and I would love to get as many people involved in that as we can. Thank you very much.
Thank you very much, Julia, for your presentation today. I love the way you used SAM to illustrate the theory of identity and the critical importance of understanding identity when supporting people with brain injury. Who we are and who we think we are is so much a part of how we're able to engage with the world that I think that your research is really important. We all want to give research-based care. Evidence-based practices is a big phrase for many of us who are in service provision, so thank you very much. For all of you who are listening today, I'd like you to take just a moment and reflect on what stands out for you from Julia's presentation. What stands out for you from Julia's presentation? And if you could put that comment, that reflection into the chat box, we'd really appreciate that. What stands out for you from Julia's presentation? It's now my pleasure to move on to our final speakers today, to introduce Karen Mason and Dr. Paul Van Donkelaar and their presentation, Moving Ahead, Exploring Brain Injury and Intimate Partner Violence. Karen and Paul have agreed to have a short question and answer period after their presentation. This might be just 10 minutes long, but they'll be able to answer at least a couple of your questions. Please use the Q&A box for submitting your questions. Karen Mason is co-founder and director of the community practice for SOAR, Supporting Survivors of Abuse and Brain Injury Through Research, and former executive director of Kelowna Women's Shelter. A seasoned and passionate nonprofit leader, communicator, and community collaborator, Karen brings 30+ years of career experience to her work, advocating for survivors of intimate partner violence. Dr. Paul Van Donkelaar is co-founder and principal investigator for SOAR, Supporting Survivors of Abuse and Brain Injury Through Research, and a professor in the School of Health and Exercise Sciences at the University of British Columbia's Okanagan campus. His program of research focuses on the basic mechanisms of sensory motor control and the cerebrovascular, neurocognitive, and sensory motor aspects of brain dysfunction resulting from traumatic brain injury. Now, the fun fact, and I've got this from Janelle, is that Karen and Paul met on Tinder, and they're now married, and apparently they often talk about this. So please welcome Karen Mason and Paul Van Donkelaar.
Thank you so much, and thank you for that lovely introduction and for having us here today. Before we get started, I wanted to acknowledge that we're coming to you today for this great event from Kelowna, BC, on the unceded territory of the Silks Nation, the Okanagan people, and we are grateful to be able to live and work in this beautiful place. So we want to start with some information for you. 1 in 3 women experience intimate partner violence. Now, this is a stat you may already be aware of, but we can say pretty globally that this is a fact. Every 2.5 days in this country, a woman or girl is killed violently, usually by a male partner or family member. And every night in Canada, more than 6,000 women and children find safe haven in women's shelters as they're fleeing intimate partner violence. just want to go a little bit over the definition of intimate partner violence. There are a lot of names for it that people use. Domestic violence, gender-based violence, family violence, and abuse. We prefer to use intimate partner violence, but it all refers to the same thing: incident or pattern of incidents that have to do with control over another person. This is a list for you of the types of abuse that can occur. I think often we tend to just think about physical abuse, which is often blows to the face, head, and neck, but there are a whole range of other ways that abuse can occur, and these inappropriate power and control dynamics can happen. This is a question we get asked a lot, and the question really should be, why does he abuse her? However, there are a range of reasons that a woman might stay or be in an abusive relationship. This captures some of them. Fear is one that is really critical when you know that women are most likely to be physically harmed or killed at the time of leaving an abusive partner or soon afterwards. So often women in some way feel safer staying in the relationship. A range of other reasons here. There might be the stigma, the guilt. They don't have support from family members because to the rest of the world, he seems like a good guy. He may be a pillar of his community. He's only abusive in the home. But the key piece that we tend to forget sometimes is this is the guy she loves, and he's not a monster all the time. As I mentioned before, most extreme incidents of physical intimate partner violence involve blows to the face, head, and neck, and strangulation. And we know that as many as 92% of women who have been in intimate partner violence may also suffer a brain injury as a result.
But what do we hear about most often in terms of research and public awareness is quite typically around sports concussion. And so better understanding how athletes, particularly in contact sports like hockey and football, get exposed to brain injuries and what can be done in terms of minimizing the risk of playing those sports and helping people recover their function afterwards.
So something to consider: in the United States, the Centers for Disease Control reported that 2.3% of women will experience a severe incident of intimate partner violence every year. So if you translate that into Canada, that amounts to 230,000 women in Canada every year experiencing a severe incident of intimate partner violence. Take that 92%, that means over 212,000 women in Canada every year are experiencing a brain injury as a result of being in that relationship.
How does it compare to what we see in hockey? So if you take a look at NHL players, it's hard to get exact statistics because of the way they report their injuries, but some recent articles have suggested that around 38 NHL players will suffer a diagnosed concussion every year. And so what that means is that for every one NHL player that gets a concussion, about 5,500 Canadian women suffer the same injury. So the numbers can be staggering when you think about it in any depth.
In terms of how this happens in intimate partner violence, this is a list of some of the mechanisms for the injury. And these are all very common types of violence that will occur in an intimate partner violence relationship. I want to take a second to talk about strangulation. Half of women in intimate partner violence report being strangled. And that is an incredibly dangerous form of abuse. It is the biggest red flag for future fatality. In fact, the Institute for Strangulation Prevention in the United States says that a woman who is strangled by her partner is 750 to 1,000 times more likely to be murdered in a future incident. So this is a really critical piece to keep in mind. The other thing to consider is that strangulation obviously can cause brain injury. And women can show up after strangulation with no visible injuries at all, but could have damage that could cause them to have a stroke and die within weeks or even months after the injury. So paying attention to strangulation as a mechanism of brain injury and death in abuse is really, really critical.
Some of the things that you can see after brain injury, including in survivors of intimate partner violence, are common signs and symptoms like headaches and fatigue and depression and sadness and sensitivity to noise and light. And this is true whether it's a sports concussion, a concussion from a fall or a car accident, or in survivors of intimate partner violence.
And how this tends to manifest, particularly with women who might be staying in a women's shelter because they have fled their abusive partner. all these sorts of behaviors, which many of you I'm sure are quite familiar with, given that you work with survivors of brain injury, or you are a survivor of brain injury or a family member of one. These sorts of things in that kind of group living context can cause a lot of problems, particularly if the staff and experts there aren't well versed in the implications of brain injury. So these survivors might come across as difficult and oppositional when really they need extra supports. So now this harkens to the little fun fact we got at the beginning. Just want to let you all know that 5.5, almost 6 years ago now, Paul was working very specifically on sports concussion, and I was running a women's shelter. But we were both single, and we both swiped right, and we met on Tinder and fell madly in love, because look how cute he is, and he's very smart and tall, very tall. And soon after we met and started dating, just a few months later, I saw this article about brain injury in intimate partner violence. And it was my light bulb moment. I hadn't heard of this connection before. So I promptly sent this article to Paul, and off we went.
And so we created the SOAR project, which stands for Supporting Survivors of Abuse and Brain Injury Through Research. And we were fortunate to get some anonymous donor funding to get us off the ground, and have subsequently been able to receive a number of different grants that have helped us really push this forward. So what is it? Well, it's a community-engaged multidisciplinary research project. We launched it in 2016, and it's really a partnership between UBC Okanagan and Kelowna Women's Shelter. We began collecting data both at the women's shelter and in my lab about 3 years ago now. And at this point, we have about 66 participants who have gone through the program. There are 3 goals that are part of SOAR. The first is to explore, which is to characterize the incidence and effects of traumatic brain injury and intimate partner violence. And we'll show you a bit of that data in a second. The second goal is to educate. So that is to raise knowledge and awareness of the intersection between intimate partner violence and brain injury in those who work with survivors. And the third, which we're just starting, is empower, which is to create better awareness and support services for those survivors so they can improve their quality of life in the longer term. Go ahead.
Okay, we're always bicker over who should do what slide. So the explore phase really has 2 aspects to it. The first occurs at Kelowna Women's Shelter, where we conduct a series of psychosocial assessments with the participants that are an interview-based series of assessments. It was really important for us to do these at the women's shelter, where the counselors are working 24 hours a day and where there were supports that the women were already familiar with, because some of these surveys that they were doing go into some history of their trauma and their brain injury. And we really wanted to make sure we were protecting their wellness if they were triggered or had any kinds of traumatizing issues during these. So the surveys look at everything, including PTSD, anxiety, depression, trauma history, substance abuse, and the brain injury severity assessment, which I will let Paul tell you about in a second. But it was really critical for us to look at these other factors, because women who've been in intimate partner violence regularly experience complex PTSD, anxiety, and depression. And those are also things that occur, as many of you already know, and we talked about in the last couple sessions, in and after brain injury. So it was really important for us to look for these so that we could be able to pull apart what might have been caused by the brain injury versus by the abuse.
So the brain injury severity assessment, or BISA tool, is a series of questions asking about signs and symptoms of brain injury that may have resulted from episodes of intimate partner violence. So a question might be something like, the last time your partner hit you, did you see stars afterwards, or did you feel dizzy afterwards? And if the participant answers yes, then there's a series of follow-up questions related to how frequently that happened, when was the most recent time that happened, and also how severe was it? So did you lose consciousness or have a period of post-traumatic amnesia as a result of that episode? We also asked some probing questions around whether strangulation was part of that experience, to try and get a better handle on how much of what we were seeing in our measures in the lab were due to head impacts versus strangulation, or the combination of the two. So then we bring them up to my lab at UBC Okanagan and look at a number of different measures of brain function. One that we have some expertise in is around cerebrovascular physiological measurements. So looking at aspects of brain blood flow, and the picture here on the left shows some of the equipment that's involved in looking at that. And we can look at the relationship between blood pressure and blood velocity to get a sense of what's called cerebral autoregulation. So this is just really how you regulate blood velocity going into your brain when you have changes in blood pressure. And so the changes in blood pressure that we induce here are simply by getting the participants to do alternating stand squat maneuvers. And so when you squat down, your blood pressure goes up. When you stand up, your blood pressure goes down. And really it's the relationship in terms of the timing and magnitude between those two measures that we're interested in. Second thing we do is make use of a sophisticated computerized robot tool called the KinArm to look at aspects of complex cognitive and sensory motor function. We've got a little short segment of video here to show you what participants were asked to do. So this is the object hit and avoid task that is implemented in KinArm, and basically the participants are meant to hit targets as they're coming down from the top of the screen and then avoid distractors. And I think they're in this example, they're meant to hit the vertical rectangles and the circles and avoid all the other targets. So we'll just show you a short segment of video to give a sense of what this is all about. And as the trial progresses, this is just a short segment, the targets come down faster and faster. And eventually you start to make errors. You miss some of the targets or you accidentally hit some of the distractors. So this is a relatively short presentation, so we don't have a lot of time to go in details, but we'll give you a summary of what we found so far. So based on the brain injury severity assessment tool, the majority of the participants that we recruited had experienced at least one episode of intimate partner related brain injury. The number of symptoms that they had when we tested them in the lab was actually greater than what we had typically observed in acute sport-related concussion. And the interesting part about this is that the average time after which we tested the survivors was about 1 year since the most recent episode of intimate partner violence. So clearly these are chronic symptoms that they're experiencing. For the cerebral vascular physiological measurements, the key thing that we found is what we're calling arterial stiffening. So it's basically the relationship between blood pressure and blood velocity was consistent with a stiffening of the arteries going into the brain. And that arterial stiffening has been linked in to long-term neurodegenerative processes. So it's not a good thing. For the KinArm movements, we found that participants had a reduced ability to make fast coordinated movements. So they were less coordination and had to move more slowly in order to hit the targets. And that when we looked specifically at strangulation, those that had experienced strangulation at least once tended to have higher BISA scores. And interestingly, even though we weren't specifically looking for differences between Indigenous and non-Indigenous participants, what we found was that Indigenous participants were overrepresented. So they were about 20% of the population, 20% of the participants that we looked at were Indigenous, whereas according to the latest census poll of the Kelowna region, Indigenous people represent about 6 or 7% of the population. So indicating that Indigenous women are more likely to experience IPV than non-Indigenous women. And they tended to have higher BISA scores, so higher scores on this brain injury severity assessment tool, but reported fewer episodes of strangulation. So at the end of the day, these participants had experienced repeated brain injuries through a combination of head impacts and strangulation. These resulted in chronic symptoms that we were able to measure in a number of different ways that likely have long-term consequences in terms of their overall health. And one final thing I should mention is that we took into account in all of this the potential comorbidities, so the post-traumatic stress disorder, the anxiety, depression, et cetera. So each of these results accounts for these potential covariates that can influence the measures that we made.
So phase 2 of the SOAR initiative is the educate phase. And the focus really is on, as Paul mentioned earlier, creating education and training for those who work with women, either in women's shelters or frankly, almost any capacity, given the high numbers of women who've experienced intimate partner violence, and also for the general public and other professionals who may or may not be aware that brain injury really is a key factor in women who've experienced intimate partner violence and don't understand the challenges that that can create for survivors. So part of what we did to develop some of the training materials we've created is we surveyed 150 women's shelter workers from across Canada. And what we learned was that they did not know very much about brain injury. It was not something they really incorporated into their daily practice, but they wanted to learn. We found at the time at least 75% said they were not screening for brain injury in any kind of formal way. And we know the number was probably actually higher. The 25% also that were screening for it may have just included if in a conversation with a woman at her intake or during a counseling session, a mechanism of injury was discussed. And so they said, oh yeah, he hit my head and we might have had a concussion. But they weren't doing any kind of formal screening with clients for whether a brain injury might have happened in their abuse experience. We also reviewed a range of brain injury screening tools to try and see if we could find one that already existed that might be useful for shelter workers and others working with women. So that was a great exercise, and we took the top ones to women's shelter workers to get their feedback as well. And we developed some training materials and workshops, today being one example of some of the workshops we've been able to present. And we recently launched something we're really excited about that we've been working on for quite some time, a special module of the concussion awareness training tool, which is specifically designed for basically anyone who works with women. It's called the Concussion Awareness Training Tool Online Women's Support Workers. And we should have an image of it, but maybe it's the next one. I'll show you this first. This is one of the pieces we have developed for frontline workers. It's just a basic brochure. This is just sort of the front and back. But the helps tool is the brain injury screening tool that we identified was the most effective, simplest, easiest, and most flexible in terms of allowing women's shelter or other frontline workers to incorporate it into their existing daily practice when they're already working in very busy, sometimes chaotic settings. So we are encouraging women's shelters and other professionals to use this slightly adapted version of the helps tool and to use it either as an assessment in this way or to just use it as a method of guiding a conversation around brain injury with survivors. And there's the concussion awareness training tool. So if you go onto the main web page, this is what you'll see, and you would click on the women's support worker. I don't know if we have it hooked up actually.
Oh, no.
No, it won't go. You won't be able to see it. But anyway, I can assure you it's fantastic, if we do say so ourselves. It's about a 30 to 40 minute online course. It will give you everything you could ever want to know, the basics of brain injury and intimate partner violence, with the helps tool and a whole bunch of other resources, as well as tips and tools on how to adapt your practice and support women who may have experienced both. So we're working quite hard on getting this out across the country and encouraging women's shelters across Canada to get their staff to take this course so that we can really expand the learning across Canada on this topic. This is another great resource on the topic of brain injury and intimate partner violence, the Abused and Brain Injured Toolkit. It is an in-depth website with everything you could ever hope to know on the topic, both for service providers and survivors. It was developed by a research team in Toronto who did an incredible job. Highly recommend this if you have the time and space and interest to do a much deeper dive into this topic.
There's also an amazing recent book called No Visible Bruises by Rachel Louise Snyder. We highly recommend, if you have, again, the time and are looking to learn a little bit more about this topic, to pick up this book. She recently was awarded a MacArthur Fellowship as a result of her work in this area. Finally, the third phase of the SOAR project is Empower. It's this community-based referral support network. The idea here is we're going to partner with a community brain injury support agency. In our case, it's Brain Trust Canada in Kelowna, and then the Regional Healthcare Authority.
This is sort of hearkening back to the last one of the sessions today, talking about that importance and need for integration of services. It's really what we're trying to build here.
So the idea is that Brain Trust Canada is going to run the intervention, which will include components of cognitive rehabilitation, clinical counseling, occupational therapy, aerobic exercise, and mindfulness and meditation. So it really is very in-depth and broad in scope. And one of the first things we want to do is basically evaluate some pilot participants who go through this and ask them about changes in or measure changes in cognitive function, quality of life, and resiliency. In terms of future goals, I think we're really interested in working with brain injury experts and experts from other sectors that may or likely do come into contact with survivors of intimate partner violence to basically better educate them and raise awareness for them around, again, this intersection between brain injury and IPV.
One of the things we've found pretty quickly in doing this work is that if we're going to ensure that women who've experienced intimate partner violence and brain injury get the brain injury and life skills supports they need, we need to ensure the professionals providing those supports are educated in intimate partner violence and trauma-informed practice. And we found in a lot of cases that may not be happening. So it's really led us to realize we need to do this cross-training. So we've been developing some other workshops and training specifically on kind of IPV 101, helping to shatter some of the myths out there and help folks understand kind of the very complex dynamics and nuance of intimate partner violence relationships, but also some basics of trauma-informed practice that can help them in serving these women.
A second future goal is to look at the potential long-term neurodegenerative effects. We've got an inkling that this is probably happening in this population, and so we want to look at both in terms of measuring people over multiple time points over time to see if there is some trajectory that they're on, as well as probe for specific aspects of neurodegeneration. And then as part of that, we are also interested in starting some neuroimaging studies with colleagues at UBC Vancouver. And then a really interesting component of this that I have a master's student working on is trying to better understand the legal and ethical implications of screening for and diagnosing and making use of information around brain injury from intimate partner violence when it comes to a legal proceeding related, for example, to child custody and parenting. And so, you know, it gets at this issue of trying to understand what the advantages and disadvantages of this information may have for the person in question.
A lot of folks who work in the gender-based violence sector have very real concerns that a diagnosis or even discussion of brain injury could be weaponized against women, both in terms of custody discussions, as Paul mentioned, but also when it comes to things such as child protection and the Ministry of Children and Families. So this is a really important question that comes up every time this issue is discussed. And we know the answer isn't to forget about brain injury and intimate partner violence and not talk to women about it and get them the help they need. The answer is to educate all those who need to be educated, but we definitely think this is really important to explore what the implications of this are so that we arm everybody with what they need to succeed.
Go ahead.
Okay, and one of our other what's next that we would love to have all of you attend if you're interested. We are hosting a conference specifically on brain injury in intimate partner violence, February 24th and 25th. It is free and online. Thank you, COVID. So we're really excited about that. We've confirmed some incredible speakers. Dr. Eve Valera from Harvard Medical School, who is, I call her the pioneer of this work. She's one of the first people to really start looking at this intersection in her work. She will be our opening keynote. And Rachel Louise Snyder, the author who we mentioned previously, who wrote No Visible Bruises, will be our second day keynote. And we're going to have sessions exploring the legal and ethical implications. We will be looking at promising practices in looking at brain injury supports in second stage housing contexts. We'll be looking at some programs that are really effective that are running in the United States. A very important session specifically on strangulation. So I think it's going to be a great event. And if you go to our website at soarproject.ca, you can sign up to receive an email when registration opens, and that will be relatively soon, I think in the next month. So we hope you will come.
Finally, we'd like to thank the support that we've received from various funding agencies to help get this project going. It's been really encouraging to see various funding agencies step up and recognize the importance of better understanding the intersection of intimate partner violence and brain injury. So thank you for your attention, and we'd love to answer any questions that you might have.
Hear me okay?
Yep.
Hi, it's Dale. Thanks, Karen and Paul. We did have some comments. Maybe Karen can address this on why, when we speak about intimate partner violence, often we tend to use the pronouns his, him for the aggressor. Can you just explain the overrepresentation of women in this area?
Mm-hmm. So we know that abuse also happens the other way, that, you know, men abuse or women abuse men, and these power dynamics exist in both. We also recognize that abusive relationships occur in a variety of contexts, including LGBTQ2. But statistically speaking, the numbers say it is more male violence against women. And in terms of the key power and control and stronger physical force dynamics that are more likely to result in a brain injury, it's definitely more on the side of male violence against women. So we do recognize the other context exists, and we chose for this research to go with what was the bigger concern in terms of the numbers, and again, that possibility of harm and physical damage because of, generally speaking, the differential in size and power and control.
Great, thank you. Could you also maybe address in your research how mental health and addiction affected some of the women?
Yeah, so, you know, we mentioned that we did assessments of, well, PTSD, depression, anxiety, substance use, and history of abuse. And, you know, absolutely, you know, all of those measures were higher than what you would see in the general population. And so, you know, I guess it's naive to think about this idea as you know, IPV leading to brain injury in isolation, right? And so really an important piece in all of this work is to take into account and acknowledge the complexity of the experience, whether it's to try to better understand the function of the brain or the structure of the brain in this population, or provide appropriate supports, whether it's education and awareness to people who are providing those supports, or actual, you know, the community-based supports that we're starting to work on. I think it's really important to acknowledge that that complexity exists within those supports, and then actually implement appropriate measures and responses so that each of those components are addressed in some way.
Certainly in the community support network intervention, there is a counseling aspect to the program. The women will meet with a clinical counselor every 2 weeks as part of doing this rehabilitation program. And we also have a client navigator advocate role who will work closely with the women, who is a trained supporter for women who've experienced intimate partner violence. So we're definitely making sure we address those coexisting issues of anxiety, depression, PTSD.
Great, thank you. There's another question. Have either of you done any work with the RCMP or BC Prosecution Service regarding awareness around the prevalence of ABI in intimate partner violence?
We spoke about 2 years ago now, I think, to the province's domestic violence units. So all the RCMP integrated domestic violence units, which represents RCMP, prosecution, victim support, Ministry of Children and Families, and the local women's shelters. So we were really pleased to have that opportunity and know that it is on the radar. I actually just finished a 5-day intense course on strangulation and intimate partner violence. And I was really pleased that in our group of 160, there were 15 from Canada, many of whom were RCMP. So that has created some really great new opportunities for us to connect with the law enforcement side of things so that we can push this education further.
People don't always recognize brain injury as strangulation, trauma changes on the brain, and sometimes even a repeated hit to the head. Do your screening tools help with questions to ask participants if this has happened to them?
Yeah, so the brain injury severity assessment tool is the way we get some insight into that. Certainly it's self-report, it's retrospective, it's about what happened in the past, and so that's always going to be open to bias and potential inaccuracies. But it's the best we have at the moment, right? It's I come from the world of sports concussion where it's a relatively clean injury mechanism, and it's a clean subject population from a science perspective, because a large proportion of the time the injury is witnessed by everyone who's in attendance at the game or the practice. Quite often there's a healthcare professional will make an assessment sometimes within 30 seconds to a minute after the injury occurs, and then if a concussion is suspected, the person will be referred to appropriate healthcare professionals, and follow-up assessments can occur. That doesn't happen in this population. There's no way for us to do that from a scientific perspective. And so we take those things into account based on the self-report of the person, the participant. It's because of the stigma of intimate partner violence, it's also quite rare for survivors to go to healthcare professionals, whether it's an ER or a clinic, to get services and support unless the injuries are more severe and they have to go. And so certainly in the case of a mild brain injury or a concussion, I think the person is not very likely to go and seek that help because, like you always say, it's their normal, right? And so they live with it and they adapt to it.
I think part of what we're working to educate folks on, particularly those who are working with women, is to really be aware of the language they're using. So, we speak of strangulation because the act is strangulation. It isn't choking. You're not losing function because something is blocking from the inside. However, we talk to women in different terms. We talk about choking because that's often how they would know of it. We talk about, does your partner ever do anything that makes it hard for you to breathe? Or have you ever seen stars because of something your partner did to you, which is how the BISA positions it. So I think the language and how you speak to women and the questions you ask can really help get to some of those things that may not even be as obvious to them immediately.
Thank you very much, Karen and Paul. Kik spoke earlier about the power of partnering and collaboration. I don't think she had quite the type of partnering that you two have done personally, but certainly the tremendous power of collaboration between sectors that may not have collaborated in the past, and that would be the sports injury and concussion and intimate partner violence. So thank you very much for your presentation today and for introducing us to SOAR and to a number of other resources. Really appreciate your time, including the Q&A. As we move on towards the end of today's session, I'd like you to think about what stands out for you from Karen and Paul's presentation, and just add that in the chat for us. What stands out from their presentation? That might be what you learned, what you thought was unusual or new. What stands out for you from Karen and Paul's presentation? If you could just add that in the chat, that would be very helpful to us as we summarize our session today. And we have another poll for you, and this is just a simple yes/no poll. And Nikki, if you could launch that. It's regarding the abitoolkit.ca website that Karen and Paul mentioned. It's about understanding intersection of intimate partner violence and traumatic brain injuries. Just, are you aware of this or not? And as the answers are coming in, it looks like a few are, but perhaps more are not. And then as the answers come in, Nikki, you'll close that when you think they're slowing down and publish it. So we see that about, a majority, 70% of people who've answered the poll were not aware of this website. I had a look at it the other day. It's really an excellent website. So thank you very much. Thanks again, Karen and Paul. And you can continue to answer in the chat what stands out for you from their presentation. I'd now like to invite Kix Cheaton to join us again to give us a summary of what stood out for her in all of today's presentations. As a little bit ahead of schedule, Kix, I hope that this is good timing for you. What stood out for you as you summarized today's presentations on research and prevention?
Yeah, thanks, Shauna. It's, again, such an incredible morning of education, awareness, empowerment. I'm going to steal that from you, Karen and Paul, because I think it just encapsulates what we do and what we hope for. With the CADTH research, it is, again, just such a incredible tool for springboarding the conversations, and in so many ways this morning's focus on research illuminates, as Janelle says, the further questions. That good research inspires more questions to ask. So with the CADTH research, we're looking at that provincial context. We see what's happening nationally, and so, you know, Carly's presentation was just so clear in where we need to look next in terms of what's happening in BC. Julia, my gosh, I love this focus on self-identity as a key piece for brain injury survivors, and I have a spot in my heart for OTs, so I really appreciate that perspective of understanding the importance of self and self-identity and expressing oneself in a way that is meaningful, and helping to identify or clarify that with survivors, and to really, again, understand identity and quality of life after brain injury. I think these are key questions, and often I think that if we can support our families and friends and clients with brain injury to be able to answer the question, who am I now? And express that in a way that's meaningful to them, that makes such a difference in quality of life. So I really appreciate the work that Julia and her team is doing to understand changes to self after brain injury, and how we can support brain injury survivors and caregivers around that expression of identity. Paul and Karen, such huge fans of your work, and to say thank you for uncovering that hidden burden of brain injury within the survivors of intimate partner violence. The statistics are shocking when we look at over 212,000 women across Canada potentially having brain injury as a result of intimate partner violence. Oh my gosh. And, you know, I for one, really love that your partnership has brought that combination of what we know from concussion from the sports community into the realm of intimate partner violence, so that we can really understand and move forward. And the incredible assessments and tools that your research has developed. The IPV module for the concussion awareness training tool, absolutely incredible. I encourage everyone to really go and check that out. The CADTH tools are incredible anyways, but to have a tool specifically around intimate partner violence and concussion for service providers, for anyone to increase that education awareness, and empower our friends, family, clients to understand what is happening for themselves and how to ask those questions. That's a huge learning for me. It's not only what questions we ask, but how we ask those questions. And I thought that was really brilliant, Karen, how you explained that. So again, just such an incredible morning to illuminate the the fantastic research that's happening in acquired brain injury. And I'm really excited to use this evidence that has come forward to springboard our next steps in the change in practice and policies that we really need to see. So thank you.
Thank you, Kix, for your summary. You've really captured some of the key concepts that we were hoping would be expressed today. Thank you very much. I'd now like to invite Janelle back for her closing comments.
Thank you, Shauna. Well, I do have to echo Kix's comments because this was a brilliant session today. And I know that research and prevention can sound like it's going to be very dry, and this was anything but. It was very important. So I want to thank all of our speakers today. It's been amazing for me to work with Kix and her team and Carly and her team in getting the environmental scan complete and ready for today. And although, as Kix said, it does show that we have more work to do, there's no doubt that this scan has increased our understanding of what is available and what more may be needed. And all of us were surprised at the results coming in from BC. We know that there's people out there doing great work, and we are going to find out how we get that information. So this is just step one. Paul and Karen, thank you so much for your presentation. Your research has indicated a huge gap in service provision because the women you have identified likely have multiple injuries that span many years and will not have any medical documentation. These women will not meet the criteria to access the services that they need. We need to look at that criteria and eliminate existing barriers. An even tougher question comes to me from the work the Cridge Centre for the Family and the University of Victoria did around intimate partner violence. They interviewed women they serve to determine how many of the abusers who caused the women's brain injury possibly had a brain injury as well. Sadly, they identified 100% of the abusers also had a brain injury. So sadly, that's the way it is. And the tougher question for me is that in order to end violence the way we all want to, we need to determine how will we serve these men too. Given what we know about challenges with emotional regulation, mental health and addiction issues following a brain injury, we can no longer expect the violence to end if we do not provide the interventions the abuser needs as well. Thank you so much, Julia, for your presentation. Your work is fascinating, and we are looking forward to hearing more about it. And I certainly can say from my family's perspective that our roles and responsibilities shifted dramatically after my husband was injured. And it impacted his mental health, and it impacted my mental health, and it impacted our children's as well. So it's really important work, and it continues to be work that I do with clients today, is to say hello to who they were, goodbye to who they were, so they can say hello to who they are today. And again, I want to thank the amazing team behind us who have all been masked up and doing the best they can to keep this running smoothly, and to Shauna for being an amazing facilitator. Again, this has just been fantastic. And to all of you who took the time today to watch and listen, thank you. We hope you'll join us at the website for further discussions, and do take time to complete our survey. I do want to say that we are noticing our surveys are lacking in input from survivors of brain injury and family members. And I have had contact from some who are concerned about making comments because they are receiving services. We want to assure you that these surveys are anonymous, and they are being tabulated by an independent evaluator outside of us, and she's just bringing the information back. So please do not hesitate to go in there and answer your questions. And as the last 2 weeks, we do have a $25 gift card, and we will announce the winner for next week when we get here on November 10th for our final session, Reinforcing Communities. Thank you.
Thanks very much, Janelle. And we're coming towards the end of our session. It looks like we might end early today, early to lunch. This is the time when we ask our word cloud question. And in the last 2 webinars, I've asked for 1 or 2 words. And it might be hard to answer this question this time with only 1 or 2 words, so maybe 3 or 4 or 5, but try to keep it as concise as possible. So our word cloud question today, and you can type your answer in the chat. From the research presented today, so the CADTH research, the environmental scan on the intersection of brain injury, mental health, and addiction, Julia's research on identity and the impact of brain injury on identity, and from Karen and Paul's research on intimate partner violence and identity. So from the research presented today, what's one area we need to act on now? I know that's a hard question because we need to act on a whole bunch of fronts. But if you could choose one area that needed to be acted on now based on the research you heard today, what would that one area be? And if you could put your answer in the chat, we'd love to see that. And as Janelle did, I'll remind you to go to the website, to the headstogetherthinktank.com. We have discussion groups there. We will have the video recordings of all of these sessions once they've had a little bit of polishing through post-production work. There's a discussion group specific to each of the webinars, and so you can find that on the website and post any questions that arise for you today from the research presented. And I would like to reinforce, as Janelle said, to please complete the survey. This feedback is really important to us. We talk about it as we plan for the next session, and your information will also help us be informed for our final report. I think you'll see the link in the chat to today's survey. And Janelle already started with running the credits, but really that's my last privilege to run the credits for everyone who was involved today. Many, many thanks to our presenters, to Kix and to Carly for their presentation around the research around intersections, to Julia, to Karen, and to Paul. Your presentations today were really important in helping us learn more about the research that's being done in many ways around brain injury. I'd like to thank the team members, to Janelle, certainly for your vision, always for your vision, to Dale for managing the questions, to Steph and Nikki for the chat, to Nikki for launching the polls, Aidan for watching over us all, and for his excellent timing. And of course, to Sunset Labs here. We're able to run this production because of the tremendous support we have from Sunset Labs, Jason, Michael, Andrew, Krev, and Xenon. Really tremendous, very professional help. And of course, thanks to all of you who attend. Thanks to all of you who attend and listen, who expand your awareness, who give us your feedback and help us take this whole project forward. Thank you very much. I look forward to seeing you next week, November 10th, for our Reinforcing Communities webinar. Have a very good day today and a good week. Bye-bye.